Welcome to Head and Neck Connect, a supportive space created by the Head and Neck Cancer Alliance specifically for caregivers of head and neck cancer patients and survivors. Whether you're new to caregiving or have been on this journey for a while, you're not alone. I'm Melissa Cook, a patient resource navigator and medical speech pathologist for the Alliance, and I'm pleased to be your host throughout the program. This series is designed to equip you with the emotional support, expert guidance, and practical tools you need. Through a mix of on-demand educational videos and live online discussions, you'll connect with others who truly understand what you're going through. Together, we'll explore topics like emotional health, daily caregiving strategies, communication, nutrition, and more, with insights from professionals and fellow caregivers alike. Thank you for being here. Let's face this journey together, one step at a time.
Welcome everyone to the first session of the Head and Neck Cancer Alliance Caregiver Support Series. We are so pleased and honored to be with you here today to kick off the series with an introduction to head and neck cancer. Our goal today is to provide a 10,000-foot overview of head and neck cancer, and while we recognize that some listening may already know much of this information, we hope that this levels the knowledge field for all participants in the series. We are certainly happy to dive into more detail in the interactive portion of the webinar. My name is Janice Farlow, and I'm an assistant professor in the Department of Otolaryngology, Head and Neck Surgery. My co-presenter is Jessica Yesensky, who will be speaking for the latter half of the webinar. Together, we are head and neck surgeons at the Indiana University School of Medicine, and we focus specifically on treating individuals with head and neck cancer. In doing so, we've had the privilege of getting to know individuals such as yourself as you navigate this journey with your loved ones through head and neck cancer. The purpose of today is to provide background knowledge about head and neck cancer and to paint a map about the overall arc of the cancer journey. After today, there will be more targeted sessions focused on common issues that caregivers may face. Since we cannot possibly cover everything, we encourage you to continue your learning and involvement through other parts of the Head and Neck Cancer Alliance. So what exactly is head and neck cancer? When we are talking about head and neck cancer, we are actually referring to a whole collection of different types of cancers, which means that the individual experience of a patient with a head and neck cancer diagnosis can be quite different from person to person. These cancers are defined by the fact that they start from the inner lining of the nose, mouth, or throat, or from saliva glands within the head and neck region. These tumors may first be found because of symptoms starting from where the cancer started growing. So for instance, a tumor in the nose or the nasal cavity as shown in this picture can start with nosebleeds or congestion. If you have an oral cavity or a mouth cancer, you may have pain where it starts, whether that be in the tongue, the palate, or the floor of mouth, or along the teeth. If you have tumors in the back of the throat or in the voice box, your symptoms may start first with difficulty swallowing, speaking, or breathing. If the cancers spread, they will usually go to lymph nodes in the neck. And sometimes we find that the initial tumor is small enough that patients may not have many symptoms related to where the tumor started growing. But if the tumor spreads to the neck, that may actually be the first symptom. That is a big mass within the neck. Now, there are other cancers that can start in the head and neck region, including cancers of the skin or the thyroid gland. There can also be cancers of the esophagus, brain, or even eyes. These are obviously in the head and neck region, but are usually considered separate from traditional head and neck cancers. One of the most common questions from patients and their loved ones is, why did this happen to me and why is it happening now? Research has shown that there's lots of causes for head and neck cancer, but we can't always pinpoint the exact reason why it's happening to someone and why it's happening now. Traditional risk factors have been pretty well established in research, and these include things like tobacco, which can include chewing tobacco, and or cigarette smoking, as well as alcohol. And the two together, tobacco and alcohol, seem to have a synergistic effect, meaning the effect is greater when somebody has used both of them in the past. But there's also more newly discovered causes for specific types of head and neck cancer. These include viruses like the human papillomavirus, or HPV, as well as the Epstein-Barr virus, or EBV. The human papillomavirus, HPV, is strongly associated with a lot of types of throat cancer called oropharynx cancer. And EBV, Epstein-Barr virus, is strongly associated with many types of nasopharyngeal cancers, or cancers that appear in the back of the nose. But there's other causes that have been linked to head and neck cancer, including a history of high sun exposure, some substances like betel nut chewing, a history of radiation, and other types of environmental exposures. And then there are also reasons why someone may be more likely to develop a cancer, including conditions or medications that might suppress the immune system or the body's natural ability to defend itself against early cancers, or also patients' underlying genetics. But honestly, there are many cases where we currently do not know enough to say why a cancer occurs. And I have many patients who have never smoked or drank or have anything else on this list who still develop cancers in the head and neck. The path forward after being diagnosed with a head and neck cancer can seem very long, and it is hard to imagine what the final destination actually looks like. Healthcare providers can't really tell you exactly what to expect, especially since the journey can be so very different from person to person. There are some common aspects of the head and neck cancer journey, though. So for the rest of the session, we will talk about them very broadly in 3 parts: diagnosis, treatment, and life after treatment. So for this, I will turn it over to Dr. Yesensky.
The process of getting a diagnosis can often be a little bit of a journey in and of itself. Once there is something identified that needs to be worked up, it sometimes can be challenging to get to the appropriate doctor in order to finally reach that diagnosis. So from an ENT standpoint, we often work very closely with primary care doctors. Dentists and oral surgeons are some of the more common people that will end up sending referrals to our office. And with that, when we have patients come in, they're being sent to our office with some sort of notion that they have something that needs to be worked up further. And it can be a little bit nerve-wracking waiting for these things to happen. And I always say to patients, from the time that they see me in the office and we start the process of getting a diagnosis to the time they ultimately start treatment is actually the hardest. And it's because you're sitting there and you're waiting and you're wondering, and your mind is going to go in a million different directions, down a lot of different rabbit holes. It's easy to get on the internet and to start looking things up. And again, you just go down a lot of different paths because you're just not sure. And so the process then really starts when you see us, and there are a number of different ways that we can work to achieve a definitive diagnosis of what's going on. A lot of times that comes with a really good physical exam in our office where we're able to look at all the areas that need to be looked at, the site of concern, and that gives us a sort of a preliminary sense of what is going on and what we think. Sometimes that includes us taking a look with our what's called a flexible laryngoscopy, which is a scope that goes through your nose and allows us to look at the back of your throat. We take a feel with our hands inside your mouth as well as on your neck. Then from there, we really utilize things like biopsies and radiographic scans to then provide more information and again allow us to achieve that definitive diagnosis. So biopsies are a way for us to take a small sample of the area or what we suspect to be the cancer or tumor and look at it under the microscope so that we can identify what type of cancer it is. And those biopsies can range from a small needle that goes into the site, oftentimes into the area in your neck, or it can be done through special instruments through your mouth or through the back of your throat. And again, it really just depends on, where the site of the concern is. Sometimes these biopsies can be done in clinic. Sometimes you actually have to come back to the hospital. And sometimes you even have to go to the operating room to get these biopsies. But that's one of the first steps. Another thing that we need to do are to get radiographic scans, which are usually in the form of a CT scan, an MRI, and a PET scan. And oftentimes it's some mixture of all of those. CT scans are the scans that people are most familiar with, and they are a short scan where you get some dye through an IV, and you go through this donut and you come out, and it usually takes about 10-15 minutes. Then the MRIs are the longer scans that you get when you go in through the tube, and it's really loud, and they can take closer to 20 to 40 minutes. And then the PET scans are scans that are whole body scans looking at sites distant or outside of the site of concern, making sure that we evaluate all areas of your body. And with that, all those things put together will give us our diagnosis and then help us determine what we think the next best steps for treatment will be. And we really need all of those things in place for us to decide. And as you can imagine, that's going to take time and multiple visits to get these things done. And so from the time you see us to the time of that diagnosis and all that, what we would call information gathering, can take somewhere around, 1 to 4 weeks. And in that time, it's just very challenging. So just a heads up to know that that's a really tough time. And again, it can take upwards of a few weeks to get that done. Once we have the definitive diagnosis, then we can start to formulate our treatment plan for you. And when you are in an ENT office or a head and neck office, those are your surgical oncologists. And they will help you come up with and formulate what is the best course of action to treat whatever diagnosis you have. We use what's called a multidisciplinary approach. And essentially what that means is the surgical oncologists also work closely with the radiation doctors and the medical oncology doctors, the ones that give chemotherapy, to formulate a plan that is best suited and tailored to your cancer. And that's a really important piece of this, is that there are multiple doctors that are weighing in to make sure that that we are on the right path for you. These doctors follow national guidelines, and we have these in place that essentially help us with the algorithm of treatment, meaning that we have recommendations on how to treat these cancers based on lots of data from people who have had similar cancers like yours in the past. And so we have good data to say this is the best way for you to approach your cancer and get it taken care of. So the surgeons are usually the head and neck oncologists. They do the surgery to take the cancer out and then, if needed, to rebuild the area that was taken out. Radiation doctors, the radiation oncologists, are the ones that would talk to you about radiation and what that entails. And then, of course, the medical oncology doctors give the medicines or the chemotherapies for that. Oftentimes, you will meet with all three of the teams so that you are familiar with them and you know about what each treatment really entails before you would even start that treatment. And just to note from the prior slide, with treatment, a lot of patients actually require multiple modalities of treatment, meaning that they would need surgery plus additional therapy, or like radiation or radiation plus chemotherapy. And some people need chemotherapy and radiation, and then after that still requires some surgery. So those are not all just independent. They can be used together, and so sometimes people need multiple treatments for their cancer. And so then after treatment, life really does take a bit of a change, and we really say that you will develop your new normal. And healing really takes a long time, whether that's from surgery or whether that's from the non-surgical side of things. The first year after treatment is really the time that we say most of that healing is done. And I would say it's really the first probably 3 months after finishing whatever treatment that you have that are going to be sort of the toughest. And around that 4th month is when I've seen that patients really start to get back to a spot where they feel a little bit better. And so it certainly is, a challenge and an uphill battle, but definitely something that people can get through and worth it. After having the treatment, we have regular visits in our office, and every doctor's a little bit different in terms of how they manage their surveillance. But typically, in the first year, we have you come back about every 3 months. That changes to about every 4 months the second year, and then the 3rd and 4th year we look at every 6 months. And that's because we want to keep a really close eye on you after you finish treatment to make sure that we don't see this cancer come back. Because typically cancers return within the first 1 to 2 years after treatment if they do come back. And so we really want to be vigilant and really keeping a close eye on you. That typically involves you coming into clinic and us evaluating you. There is also the use of either CT scans, MRIs, or PET scans that can help us further make sure that there isn't anything going on. And oftentimes it's a mixture of all those things that we use to survey you. We also utilize our speech and swallow team who will essentially, work with you throughout the entirety of your treatment to regain those functions. A lot of the cancers that we see involve some element of our speech and swallowing capabilities, and so that's a big part of what we do in terms of rehab. And you can think about the speech and swallow team as essentially it's like physical therapy for those things, and so it's absolutely necessary that you develop a good relationship with that team, because they work really hard to get you back to a spot of the sort of optimum amount of function. And with that, we also work with our physical therapists as an occupational therapist, again, to regain as much just overall function as we can. Oftentimes, with the surgery, not only do we take the cancer out, but we also have to borrow tissue from somewhere else to help rebuild. And so we want to make sure that those spots that we borrow the tissue from, like your arm, your leg, and sometimes your chest, that you are still able to use those parts of your body well. And again, just sort of overall getting back to a functional spot where you're doing things that you were doing before you were diagnosed with this cancer. And as I alluded to on the prior slide, is that this is really a team approach, and this is that multidisciplinary a team that we're talking about. It not only includes the oncologists, so surgical, radiation, and medical oncologists, but it is everyone else who is as important in your treatment and recovery. The speech and language team are those a backbone to your recovery in terms of your ability to eat and drink again, as well as speak and communicate. The physical and occupational therapists, again, the same idea of getting you back to, a functional spot where you're able to enjoy and do the things that you were doing prior to this diagnosis. The nutritionist will make sure that during this time you're getting all the nutrition that you need so that your body can sustain and then also, fight the battles that they're fighting as you're going through this cancer treatment and recovery. Social workers and case managers make sure that you get all the things that you need outside of the hospital, whether that's equipment, rides, all the things that you wouldn't really think about in terms of going through cancer treatment, rides to places, sometimes gas cards, helping you find hotels, helping you find local resources, things that just really you don't realize are a huge impact in your ability to get treated, but are certainly there. Psychiatrists and psychologists are, again, another big part of this because in addition to the physical changes that you have, it's psychologically a big drain to go through cancer treatment for the patient themselves as well as the family around them. It's a big deal, and it's oftentimes a lot to go through, and so we utilize them. Pain management and palliative care, another big team. Those are things that are necessary before, during, and even after treatment. One point with the palliative care too is that when people hear palliative care, they think that that's the end or end of life things, and it's not really. Palliative care is essentially this amazing team that works to help manage all the other physical things that are happening to you with the cancer diagnosis. So whether that's an appetite, your pain, your energy, any sort of issues with your GI system, any sort of, psychological issues that are going on. These are all things that they address and can get you either medicines or resources for. So they're an imperative team for oncology, for the oncology services. Geriatricians also, same idea, and utilized for some of the patients that reach certain ages. And then other patients and caregivers, I think it's good to know that there are support groups of people who have gone through similar things, and it's really nice to be able to sort of commiserate and compare and sort of get an idea. I think one of the hardest things is that as you're going through this, knowing sort of what's normal and what to expect. And, as physicians and providers, we can offer what we see in our anecdotes, but to hear it from another patient, I think who has actually gone through it, is something that is just invaluable. And so there are definitely support groups to talk about these things, what their life is and what their journey was during and then after treatment. And then, of course, caregivers as well. It's important not to forget that they are a major part of the treatment process, and it can be very trying from their standpoint too. And so we really have to make sure that everyone's needs are being addressed during this time.
Well, we and the media often talk about how hard cancer is on patients themselves. We know that it is a difficult journey for you as a caregiver as well. While you are the person who may help someone with cancer the most, you are not paid to do so, and you are usually not trained to be a caregiver. You can have many different roles throughout someone's cancer journey and are asked to selflessly navigate every turn in the road and weather every storm. It can be a lot to know that you can have a huge influence on how someone experiences their cancer journey from day to day. So please know that we recognize how challenging your role as a caregiver can be. We hope that this support series has been helpful in the start of your journey, and we look forward to partnering with you to figure out how we can better support patients with head and neck cancer and caregivers like yourself. Thank you for your time today and all that you are doing for your loved ones.
I'm honored to introduce Dr. Amy Halter, a licensed professional counselor, professor, and caregiver whose work is deeply personal. When her father was diagnosed with head and neck cancer in 2023, Amy put her life on hold, pressing pause on her doctoral studies and moving in to become his full-time caregiver. Her lived experience shaped her dissertation research, which explores the realities caregivers face and the critical need for emotional and practical support. Dr. Halter brings a unique and compassionate voice to our conversation, someone who understands both the science and the soul of caregiving. Please join me in welcoming Dr. Amy Halter.
Hello, my name is Dr. Amy Halter, and I am so excited to be a part of this Head and Neck Cancer Connect group. I have a unique experience that I want to briefly share with you. My dad was diagnosed with head and neck cancer in 2023. I am also a researcher, and I have been doing a lot of research on family cancer caregivers, and especially those whose loved ones are diagnosed with head and neck cancer. So I have had the unique perspective of experiencing, both levels of this. So I look forward to sharing my experience with you. I live near Pittsburgh, Pennsylvania. I am married. I have 3 kids. Only one is still at home. He is 14, and my other 2, one's in college and one is having, her grown-up job. And that matters because in my experience, when my dad was diagnosed, it's like nothing else existed. I had to stop everything. I took a year off of my PhD program. I moved in with my dad, even though he's only like 15 minutes away. My sole focus was on him and his treatment. And I'm sure many of you can understand that because before this moment, I had no experience with cancer. I'm a counselor and I'm a professor. I'm a researcher. So I do not have any experience with nursing, or any medical training. So my dad was diagnosed, and quickly he had a massive 18-hour surgery where they took the tumor out, recreated his jaw, did the skin flap from his leg onto his face. It was brutal. Even though I had talked to the doctor, I had no idea what was really going to happen. So, being in the hospital for that long, he also had a trach as well. And when it was time for him to discharge, there was that panic of what in the world am I going to do? I had the idea that visiting nurses were going to come every day and we were going to have all of this care. Well, none of that happened. He was discharged home, and the suction machine came, and I was YouTubing, how to use it. I had training on, how to take care of the wound on his leg, his stitches, and all the while being like, I have no idea what I'm doing. I am his daughter. I am not a nurse. But through that journey, that's exactly what I was. Visiting nurses came maybe once a week, but I was responsible for so many things. His appointments are about an hour from our house. So, there was that, driving. And then as he went through his recovery from that surgery, radiation and chemo started. And I remember sitting there thinking, no one asked me if I would be willing to drive my dad 2 hours round trip to radiation 5 days a week for 6 weeks. It was just assumed that that's something that I would be able to do. Now, of course, it's my dad. You all have loved ones too. So saying no is really not an option. But I just remember feeling like, my whole identity and my whole life is now revolving around the health and wellness of my dad. So when he started all of these treatments, they handed me a big binder full of everything that needed to be done with my dad. If his temperature was a certain thing, how to treat, expect. No one ever gave me any information as the caregiver. No one ever checked in on me. No one ever said, how are you doing? Sort of like, oh, here's Amy again. We see her every day. Or how do you do it? Well, I don't know how I did it. I just did. Stress of my dad, but then I had the stress after of taking care of him, helping him with the radiation, burns to his neck. At this time, he was on a peg tube, and he had a pretty bad experience with necrosis that actually caused the bone that they had placed in his jaw to crumble, and we were facing a whole other surgery because the benefit of radiation also caused him a lot of harm. So throughout this journey, it has been physically taking care of him. It has been, doing, the bills, the grocery shopping. My dad lives on a lot of land, um, yard work. And I always say that there's two things that I could not do. I cannot cut wood because we're rural Pennsylvania, and I could not plow his crazy driveway. But honestly, other than that, I did everything else. It impacted my friendships because no one wants to hear about cancer all the time. I stopped calling because that was the center of my world and that was everything I was talking about. It impacted my work. I took a leave of absence. Obviously, I took time off my PhD program. Um, I remember when it was time to go on my family vacation with my husband and my kids, I thought I was going to have to be admitted to the hospital because my anxiety was so high and my worry of what's going to happen when I'm not here. I had my sisters come in. They're from different parts of the country, to stay with him because I just couldn't do it. And I also know during this time I wasn't taking care of myself. I missed so many doctor's appointments, like yearly exams. Um, I wasn't eating, sleeping. I felt constantly, and I never had time to, exercise or leave. And I mean, I guess I want to make it clear it's not like my dad demanded any of these things, or I'm not sure how they would have ever, gotten accomplished. So, my dad had a second surgery that did not go as well, and that led us to the Cleveland. Actually, in fact, I drove him yesterday. We're talking 6.5 hours in one day, up there for appointments and then back home. So, needless to say, getting up this morning to teach. And I kept thinking the whole time driving there of what a blessing this is. But, I will also own that I felt a lot of anger because I have a lot of my own work to do. And a lot, he's the most important person to me. So, of course, I do it. But it does impact me as it impacts, all of you. So, my dad is cancer free, knock on wood. He continues to have a peg tube, which involves, me helping him make full blown meals that we puree and storing containers so that, he can do the bolus feeds. I have stepped back in certain things like setting up his medication. I don't do the bolus feeds for him anymore. He crushes up all his own medication. Um, but again, I don't think people realize how time consuming those things are. And, I have transitioned to a lot of that, but I still do, the appointments and the coordination of care and, just checking in, reminding him to flush his tube with enough water to stay hydrated, reminding him just of many different things because he's not got his strength back. Still has a lot of issues from radiation like lymphedema and neuropathy. But, he is in a good place. It is very difficult in our family since he cannot eat. So, everything revolves around food. So, holidays, either I'm not eating or I eat in another room, even though he says, it's totally okay. But I've seen how that impacts him with his group of friends and, the different things that they have from Super Bowl parties to, um, he rides a three-wheel Harley now, to going on different bike rides that involve food. So that's still a hard thing, in our family that we have to deal with. And, I've experienced his anger when I have reminded him to do his swallowing exercises or use his lymphedema machine. And, you know, I think I'm a little bit intrusive in some of those things, but I want him to continue, his recovery in the best possible way. So that led me, when I was doing my dissertation research for my PhD, to start looking at family cancer caregivers and the research behind our lack of wellness. Looking at the research that says if we ourselves are not healthy, then our cancer family member is not healthy. They often miss appointments. Maybe medication isn't as consistent. They start to neglect some of their care because their caregiver has simply run out of gas. So I wanted to learn, what we can do at those appointments, whether it's survivorship, whether at oncology, whether at your ENT or plastics appointment on, how can we look in on the caregiver? So, I have been working very hard on a survey that caregivers can take because, we all get the iPads about our loved one's symptoms. Every time we register for an appointment, that kind of triggers, are they sleeping? Are they eating? How is their energy? All of those things. So I think a simple caregiver survey would be wonderful, especially looking at how we are in the beginning when it feels like we're so proactive, we're all in, to that treatment phase, that surgery phase, radiation and chemo, how it takes so much out of us, as well to what if we are in a state of remission or if we're cancer free, how does that look? Because I'll tell you, taking it for myself personally, if I took the survey today versus a year ago, it looks very, very different. I know that I really needed help during some of those moments. I was a big advocate for my dad. I'm sure many of you feel the same way, that we just can't leave our loved ones if they're in the hospital, or, not, perhaps insurance is denying, claims or payment. But, those are other roles we have to take on to fight for. So, there are a lot of roles that we have. And I think it is up to the doctors to realize that caregivers are on the front lines. They are the ones that are ensuring all of the things that they are ordering. So I am looking forward to sharing more about this as we continue on, each week. I will have a segment kind of talking about my research and looking at a wellness model in all the different areas that we need to focus on so that we are healthy, because we cannot provide care for our loved one if we are unhealthy. And unhealthy can look different for everyone. It can be physically unhealthy, mentally unhealthy. We could be financially unhealthy, not having connections with our support group, family, church, friends, other hobbies, things like that. So those are all things that I know I'm going to be providing some insight on to hopefully, help you all with the battle that you're facing. It's not a physical battle, but you know what? It's a battle in every other sense of the word. So I look forward to meeting you all, and I look forward to also learning, from your stories as well. And I look forward to also being a support to you all, as well as we are navigating this journey together. So again, I look forward to meeting you. Thank you all for taking the time to listen a little bit about my story, and I will see you all soon. Thank you.
Thank you for joining us today for this important topic. If you have any questions, feel free to reach out to us via email at connect@headandneck.org or visit our website for more details, www.headandneck.org. We hope that you'll join us next week for our online discussion, where you will have a chance to chat with other caregivers and professionals about these important topics. It's an honor to connect with you. Wishing you strength and peace in the week ahead.